Nice. So I was asked the question, how do I control activated coagulation in sepsis? The short answer is I've got no damn idea. Can I go now? Must no? Okay. Okay, well, all right. So what do I do? How do I even think about controlling coagulation in sepsis? You know, it took me a while to kind of puzzle this out, and I kind of came up with a few basic ideas. The first and foremost is you have to look for it. You can't control something if you haven't found it. The second is, this is kind of a no-brainer, control the sepsis. Last point is, don't make it worse. Number 4, anticoagulate. We can talk about how good or bad an idea that is. You know, maybe there's some other options out there, particularly if you're in Japan. Any Japanese in the audience? Any Japanese colleagues? Raise your hand. You guys have an extra tool we don't, so, you know, be grateful. All right, so this is probably the only time at ESICM you'll have pornography referred to. I draw a parallel between pornography and DIC, or other coagulation sepsis. And this is a famous US Supreme Court justice who, when asked what was pornography, says, "I can't define it, but I know it when I see it." Coagulation issues and sepsis are kind of the same thing, right? You know, anybody think that this isn't a coagulation issue? Right? You think this isn't a coagulation issue, right? By the time you see it, you know, it's pretty damn obvious. But the problem is, as my 3 excellent co-speakers have before this, is really fundamentally coagulation issues in sepsis are a disease of the microcirculation, right? These are not immediately visible. These are hard to find. So we spent a lot of effort doing these very sophisticated tests to assess this. TAT levels, protein C, clot waveform analysis. Dr. Ufermans and I are working on viscoelastic testing as an early marker, and cell damage markers like HMGB, right? So a lot of very sophisticated, nuanced studies out there, methods out there, but there's some problems with it. One, so far they've been kind of largely based on itsy-bitsy little studies, so it's hard to convince people. Some of these tests cost about $11 gazillion. They're not readily practical, and by no means should they be allowed to be done by Muppets. By this, I mean they're technically challenging, so they're not widely accessible because of that difficulty. So where does that leave us? Well, it leaves us with these kind of syndromic definitions, which we all know have their own problems. We have entities like sepsis-associated DIC, or SADIC, and we have kind of the new kid on the block, sepsis-induced coagulopathy, or SIC. Right? But these are syndromic definitions, so which have their own lack of precision and lack of robustness. Now, if you want to think of this schematically, you can think of kind of a progression in a septic patient, well, most of them at least, from sepsis to an SIC state, kind of think of that as the early phase, and then eventually, if the wheels completely fall off, then you wind up with full-blown DIC. Right? So you can kind of think of that as kind of a schema of production going forward. Now, to identify SIC, again, you have to look for it. Right? So this is the new schema for SIC. It's a combination of SOFA score, prothrombin time, and platelet count. But if you're not checking your INR every day, or you're not looking too closely at your platelets, or God forbid calculating your SOFA score every day, you may not see someone develop that SIC, particular phase which you might be able to do something about it. So I said the first step in controlling the coagulation fix is you have to look. Now, SIDIC is kind of fairly similar. This is the ISTH score. There's a Japanese version as well, where it's a combination of platelets, INR, D-dimer, fibrinogen, and a score greater than 5 is indicative of kind of overt, terrible terminology, right? What the hell does overt DIC mean, right? Versus covert? Sure, okay. All right, so, but the idea is you have to keep looking for it because these patients also aren't static, right? It's very easy to say, oh, at kind of day 1, they've got all this coagulation, but who knows what happens at day 4, day 5, right? You have to keep looking. Now, of course, this is the kind of no-brainer, right? Control the sepsis, treat the infection, and treat it well. And that I swear we didn't plan this, that 3 of the 4 speakers all use the same damn slide. I swear this wasn't planned in advance. But it's a simple concept, right? If you think sepsis is the kind of the first mover, that first insult, you control the sepsis, you stop the monocyte stimulation, you stop the production of inflammatory cytokines, you reduce, as Sasha mentioned, you reduce the insult and the activation of the endothelium, tissue factor expression goes down, and you don't have a clot, right? So, so treat the sepsis, kind of duh, right? Now, the other point is, don't be like this, American dumbass, man from Florida. Don't make the situation worse. And this notion is basically blood product transfusion in SIC or SADIC can be like adding gasoline to the fire. You're adding more substrate. And unfortunately, I didn't have the time to insert into this talk after I uploaded it. There's actually a really nice study from China published in Shock last week that actually correlated the number of plasma transfusions with worse outcomes in SIC. So just kind of giving blood products, oh my God, their INR is 1.8, I must give plasma, may not be the smartest thing, right? So, don't be the, man from Florida. So if you look at the kind of unified guidelines on how to treat DIC, I'm going to point out kind of one theme, right? They say, well, give platelets if you're bleeding and have a low platelet count. Give plasma if you're bleeding and have a high INR. Give fibrinogen if you're bleeding and have low fibrinogen. There's a common theme, right? Only give blood products to these people if they're bleeding. Because more blood products may actually be, as Lenny points out, right? Platelets are immune stimulating. That may or may not be a good thing. So the recommendations, again, from the unified guidelines is basically blood transfusions should never be given on the basis of lab results alone, right? Just because, oh my God, somebody's platelet count is 49, I must give blood products. That may not help you. In fact, if you look at it, as Lenny mentioned, right, some of these plates are kind of supercharged, right? They actually act really well. They kind of bind to the endothelium quite effectively. So platelet counts of down to 20 or 30 are probably perfectly acceptable. They won't bleed out of their eyeballs immediately, I promise you. Now, so this is all well and great. Okay, I found it. I'm going to treat the sepsis. I promise not to screw it up more by giving, crap ton of plasma. What can you really do about it, and when? So I think you need to consider treating. And this is, trust me, I get this look all the time in my ICU. When I say, okay, someone's septic, their platelet count's 70, I know it's dropping, let's start them on heparin. And day one, I swear they look at me like I've got horns growing out of my head. You're completely insane. Day 2, when you started them on heparin and all of a sudden their platelet count's 100 and rising, you look like a genius. Right? So trust me, at the beginning they'll look at you like you're crazy. When it works, you're blessed genius. So the idea behind this is basically you can interrupt the process. Right? The way I can describe it is it's like dousing the fire. Because if you think of consumptive coagulopathies like these, the best way to stop the consumption is to stop the clot formation. And if you can't intervene upstream at the sepsis etiology, at the very least you can kind of stop or slow the coagulation process. So this is where the consideration from the guidelines is, therapeutic heparin or low molecular weight heparins are possible when you have a DIC or SIC case where it's thrombosis predominant, right? Yes, I don't recommend heparin infusion to somebody who's already bleeding out of their eyeballs. That's kind of rude. But if they're in clotting everywhere, think about it. And if it works, you look like a genius. Now, if you can't douse the fire, at the minimum, keep your foot on the brake. And by this, I mean, it becomes a very knee-jerk reaction. I see this all the time is, oh my God, this patient's platelet count is falling. It's now 90. Oh my God, stop the subcutaneous heparin, stop the prophylaxis. That's actually probably the worst thing you can do. Because believe it or not, even that small dose of prophylactic anticoagulant may be slowing the process just a little bit. Right? It may provide some mitigation of that intravascular thrombus formation. So maybe not. And personally, I tolerate platelet counts down to 30 before I consider stopping the prophylactic anticoagulant. Because that might be just that little bit of a break that's stopping the thrombosis from just going absolutely wild. Now, if you need a schema to kind of persuade the skeptics, you can kind of think about the progression of SIC-DIC like this. There's a trigger at the beginning, it activates procoagulants, and probably, in most cases, at the earlier phase, it's thrombosis predominant, right? That's why I say it's so important to look, because you may be able to catch it in that thrombotic phase where you might, and I say might, we don't have a lot of data for this, might be able to interrupt the progression, hopefully before it gets to the bleedy part. Because, you get the bleedy parts and sepsis and DIC, you're in trouble. So maybe try and prevent it from getting to that point. So if you want to think about it schematically, and this is where I think I applaud my ISTH colleagues for really kind of coming up with this idea of the SIC phenomenon is if you identify it in the sepsis-induced coagulopathy phase before they've reached DIC criteria, maybe that's kind of the golden opportunity to strike to try and interrupt this process. But again, it only works if you look for it and you're kind of willing to kind of commit to that potentially risky intervention. Now so to sum up for anticoagulants, if you find yourself in the thrombosis predominant phase of SADIC or SIC, you can consider kind of full anticoagulation, kind of therapeutic level. And at the very least, particularly if they're not bleeding, for non-bleeding SIC-DIC cases, don't stop the prophylactic anticoagulation just because some of the parameters are shifting towards abnormal. That actually may be the one thing that's keeping them from really getting abnormal. All right, what else is out there? Some old data, kind of some analysis of the old Kybercept data. Kind of interesting, right? For a drug that was kind of failed and didn't help anybody. If you actually looked at those patients that had DIC, either non-overt or overt, if they got antithrombin, they actually seemed to do a little bit better. I think we may not have, let me put it this way, it may not be a failed drug, it may have been more of an issue of a failed patient selection, that we just don't know who the right people to give these anticoagulating drugs to. So this makes me kind of scratch my chin a little bit. Maybe we just don't know who the right people to give these things to is. As Sasha rightly mentioned, plasma exchange is an intriguing idea because it can remove damaging substances that are kind of provoking these insults. It can replenish diminished anticoagulants, particularly if you use plasma for plasma. It'll reconstitute your antithrombin. It'll give you Adams TS13, some von Willebrand's factor, so it may stabilize. The downside, and Sasha and I have kind of debated this at a decent length, is just exchanging plasma for plasma, right? Giving a septic person, normal person plasma may not be entirely prudent because there are needed pro-inflammatory factors, right, to fight off that right upper lobe pneumonia that you'll then be siphoning off also. So kind of non-selective plasma exchange may have its own risk. So I say the story on that is certainly to be written, and I'm glad Sasha is studying it. Now, kind of I asked about Japanese colleagues in the audience. You all have had something for 15 years that the rest of us don't. In Japan, you've actually had recombinant thrombomodulin, which is an intriguing idea, right? If you look at this coagulation cascade, it's at the very root. It's bound to the endothelium. It helps stabilize anticoagulants. So think of it another way, right? If you increase thrombomodulin, it actually increases activated protein C production, so it kind of endogenous anticoagulant, and slows the march towards fibrin generation. So again, been available for use in Japan for 15 years now. Some small but robust data in Japan. Unfortunately, the bigger kind of global trial, Scarlet, really didn't pan out either. So again, maybe we just don't know who the right people to give it to is. I don't know. So to sum, what should you do is, stop thinking about coagulation defects and sepsis of, as like people bleeding out of their eyeballs. It's a little more complicated than that. And overall, I said, most importantly, you have to look for it. Look for SIC, look for SADIC, particularly SIC, because you may be able to intervene at that stage. This kind of, no duh comment. Control the sepsis, right? Stop the inciting event. Minimize transfusions, please, 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 particularly if the patient's not bleeding. It probably will worsen the situation. Anticoagulate, if you can, if they're not bleeding or not high risk for bleeding, particularly, again, if it's an SIC. and consider other options, particularly if you're in Japan and have access to recombinant thrombomodulin. These are kind of intriguing options that are out there, and we just need more experience, more data with. So that's the end of my recommendations for a question I really have no legitimate answer to. And I'll thank you for your time, attention, and humor.
Thank you, Nathan. Many tips for our clinical practice. Question from the floor, please. I'll start.
Stunned silence. I love it.
Yeah, great. I'll start. Nathan, of course, we were in the time 10 years ago to use activated protein C. Unfortunately, activated protein C was retired from the market, and today we have only protein C, not activated. What do you think about the use of protein C on patients with VIC?
I actually put here, my future therapy is my last point here is, resurrect activated protein C, bring it back from the dead. I think protein C, activated protein C have their place. My analysis, after the fact of some of the activated protein C data, are that, again, it wasn't a bad drug. We just chose poorly. We didn't give it to the right people. We didn't measure the right parameters, right? Why did activated protein C get pulled off the market? For the most part, because it caused a crap ton of bleeding. Because we were giving it to kind of everybody based upon the disease severity, not based upon coagulation parameters or other hemorrhage, kind of thrombosis hemorrhage balance. So I don't think it necessarily was a bad drug. I think it was limited by bad trial design and being overambitious and looking for the magic bullet, the one-size-fits-all, when really what we needed to do is be more selective, be more targeted. So I think it's really sad that activated protein C is off the market because for the coagulation defects, for example, of meningococcemia, where a large part is mediated by protein C degradation, I think it'd be a great choice. So I think there are a lot of therapies that are out there that I think are probably going to work in some people. We just don't know how to choose them the right way yet.
We have two questions, starting from there.
Yeah, thank you, Nathan, for your talk. My question is, when you use DIC or 6 scores, these are actually prognostic scores. They are not scores to direct any kind of management, And if you look at the 6 score, you're doing prothrombin time and platelet count, and that's only showing you the consumption and not really some kind of activation. Yeah. Basically, we are talking about coagulation. Well, that may be a misnomer for that system because that is a different system involved in various inflammation and immune systems. So actually, we may be doing a disservice to the system of coagulation when we are talking about managing that system. And even when we talk about activation of coagulation, I think that we talk most of the time about the procoagulant system, and we almost ignore activation of the anticoagulant system.
Yeah, great comment. Yeah, I completely agree. I think it's actually kind of silly in some ways that the only ways that we measure the kind of activation of coagulation is by the fact that they've basically outstripped, they've consumed their plasma clotting factors, they've consumed their platelets, they consumed their fibrinogen, because to some degree it's too late, right? By the time you've burned through all of your clotting factors, right, you have this kind of essentially catastrophic degree of consumption, microvascular thrombi, tissue injury. So I've been wanting to write this editorial with some of my colleagues for a while is, why are we basing all of our fixation on coagulation defects, on the notion of consumption, when what we really need to be looking at is the early markers of activation, the early markers of endothelial injury, because continuing to kind of focus on kind of post-consumption issues, it's probably too late. So if we really want to be able to have a tool to fix it, to really kind of get at the heart of it, we need to get earlier in the process and look at markers of activation, not just markers of consumption. Completely agree. Let's write the editorial together.
Sasha.
Uh-oh, now I'm in trouble.
I just wanted to comment on the protein C question from before, because I used to work in Germany and we had protein C available there. Not APC, but protein C. And the pediatric intensivists, they told me they use it all the time if they have meningococcal disease, severe purpura. And I was a little bit surprised because I didn't even know that we had protein C. So I started measuring this in cases of very severe septic shock, like fulminans or capnocytophaga canimorisum, these kind of very severe cases. And I always saw that protein C activity was really super low, like 10%. So I also gave it here and there. But I think that's an excellent example how, let's say, a lack of stratification in the trial kind of eliminated a potentially useful drug for us for a specific cohort. So in Switzerland, we don't have protein C, but I think it could work in individual patients.
Yeah, we had the same picture in Italy. Unfortunately, the data available for evidence on using protein C in pediatrics is very rare, scarce. So you use on the basis of some pathophysiological issues, but not based on data. Anyway, that's.
No, Sasha, I completely agree. Right? I think it's finding the right key for the right lock at the right time, and just thinking that kind of one anticoagulant is going to treat everybody is not just naive. I think it's dangerous. So you need to find kind of the right situation in which to kind of use these therapies, because it is they have their own risks.
We have time for the last question.
Well, just a comment again about protein C and activated protein C. Well, of course, you know that sepsis patients have reduced protein C concentration, but that doesn't mean that are having reduced concentration of activated protein C. So we are talking about two things. So what we did was we measured in sepsis and septic shock patients activated protein C and protein C. Although all of them have reduced concentration of protein C, when it comes to activated protein C, it's totally heterogenic. There were patients having higher levels of activated protein C, although they have reduced protein C concentration. So I'm not sure whether protein C per se is going to make any difference without showing the concentration of activated protein C, and at the same time looking for thrombomodulin, because you need thrombomodulin and thrombin to activate protein C into activated protein C.
Yeah, I mean, hemostatic defects are not kind of single agent defects, right? These are entire kind of pathways that then get disrupted. And sometimes it's hard to measure some of these because so many of these modulators are endothelium anchored. So, right, so we can measure in the plasma, really may not actually even be reflecting what's happening at the kind of endothelial microvascular milieu, because not all of them float in the plasma. And it's really hard to actually measure kind of the endothelium anchored moieties that are responsible for this kind of coagulation issues, right? We're kind of chasing in the dark a little bit, but point well taken.
Okay, we are wrapping up this session. Thanks to all the speakers.